Live now.
Thank you, sir. A very good evening and a warm welcome to our another edition, the September edition of Journal Club of YOSI. So I'll quickly share my screen. Right. So the YOSI Journal Club has been an initiative from YOSI to keep up with the latest updates on various topics in ophthalmology. So thanks to the governing council and its support that we've been able to carry it out without any hurdles for the past 2 years. And this is our executive team who have contributed in several ways to enable this venture of Journal Club. So the concept of Journal Club is learning and growing through analyzing and understanding articles. So, and it is to cater to all groups of young ophthalmologists, starting from first year postgraduate. They present in the form of presenters and all the way up to the consultant young ophthalmologist. So the idea is to assess research literature under these headings and structure it so that we learn the maximum out of the important articles. So the format of Journal Club has been standardized, and we have a presenter, a monthly mentor, and we have a couple of panelists to speak on the positives and the negatives of the article. And we have a keynote speaker who will be delivering the lecture pertaining to the topic of the day. So this is our Journal Club team, the dynamic team led by our Joint Secretary, Dr. Prasanna Venkatesh Ramesh, and consisting of other members. So we've been hosting the Journal Club since quite some time, and starting with 2021, 22, we've been having several sessions on various subspecialties. We've had the opportunity to collaborate with the India Journal of Ophthalmology under the able guidance of Vanati Madam. And we've held multiple webinars on important topics like biostatistics and several other topics, as you can see here. And then we've had a Journal Club in 2024 in several occasions. And in 2025, we've had again the opportunity to collaborate with Micro Labs, and they are our academic partner for this Journal Club as a joint venture. And here we are today in today's episode of Journal Club, where we have the theme of cataract and its complications. We have the presenter, Dr. Vidushi, monthly mentor, Dr. Samir, and panelists, Dr. Nikunj and Dr. Bhavya. And we have a very special keynote speaker, Dr. Matthew Kurian from Chaitanya Eye Hospital, Ernakulam. So first, we'll have the presenter for today, Dr. Vidushi. She's done her MBBS from JSS Medical College, Mysore, and DNB in Ophthalmology from Sankaradeva Netralaya, Guwahati. And she has several accomplishments to her name. Poster presentation at AOC, paper presentation, winner of the Harsha Bhattacharjee Award, and several other poster and paper presentations to her name. Welcome, Dr. Vidushi. The stage is yours. Yeah, yes, you're audible. We welcome Dr. Anujit, who will be my co-host for the day. Hi, Anujit.
Hello.
Please go ahead, Dr. Vidushi.
Thank you, everybody. Are my slides visible, sir?
Not yet. Could you please share them? Yes, now they're visible. Please go ahead.
Good evening, everybody. Before anything else, I would like to thank YOSI for this opportunity. So coming to the journal presentation today, our journal today is comparison of surgical methods for the correction of low amount of corneal astigmatism during cataract surgery, authored by Dr. Stephen C. Solhall et al. This was published in the Ophthalmology 2025 edition. So as cataract surgeons, all of us want to give our patients 6/6 vision, but with as the patients might have some preoperative astigmatic part, this might not always be possible. In fact, the article today suggests that 0.75 to 1.5 cylinder power can bring this chance down to almost 6 folds. So, as we see in this diagram here, in power less than 0.75 cylinder, these patients can either be left unaddressed, their astigmatic power can be left unaddressed, or it can be corrected by placement of an incision on the steepest meridian, giving a flattening effect. If the power is as high if it is more than 1.5 diopters, we can always resort to toric IOL. But the confusion lies in when the power is between 0.75 to 1.5 diopters of astigmatism. So in these patients, should we give a toric IOL? Should we give limbal relaxing incisions or astigmatic keratotomy, or should we leave these patients uncorrected? Is what this article is addressing today. Coming to the methods, the purpose of this study is to compare the method of corneal astigmatism management during intraocular surgery in eyes with low corneal astigmatism. It is a non-randomized retrospective study with a sample size of 40,289 eyes. The inclusion criteria comprises of patients who underwent cataract surgery or refractive lens exchange surgery between January 2018 to March 2024. Patients with preoperative corneal astigmatism of between 0.75 to 1.5 cylinder, and patients who attended a minimum of 1 month post-operative visit. However, patients who had other than in the bag IOL fixation or a complicated cataract surgery or surgery combined with other procedures, for example, a past brain aberration, or patients who have had an earlier corneal refractive surgery, or the patients with implantation of light adjustable IOL were excluded from today's study. The patients were divided into 3 groups. So among the 40,289 eyes, we had a toric IOL group comprising of 10,100 eyes, a non-toric IOL with limbal relaxing incision or astigmatic keratotomy, which comprised of 5,811 eyes. And the last group, in which no intervention was performed, this was the largest group, to 24,378 eyes. Each of these groups were further subdivided based on the astigmatic power. So 0.75 to 1 dioptric of astigmatism power was the first group, followed by 1 to 1.25, and last group was 1.25 to 1.5 centimeters. In order to assess these patients, the data was collected from a database called ZEISS Veracity Surgery Planner, and the patients among the patients from US and Canada. The variables that we studied were preoperative keratometry method, the last available post-op manifest refraction, the surgeon, the IOL model that was implanted, incision size and its location, and the type of astigmatic correction during intraocular surgery. So the aim of today's study was to assess the independent role of procedure type on astigmatic outcomes. And the primary outcome was measured by the odds of not achieving less than 0.5 cylinder post-op residual manifest astigmatism. The other independent variables were age, sex, lens model, surgeon, preoperative corneal astigmatism type, whether it was with the rule, against the rule, or oblique astigmatic power. Preoperative manifest spherical equivalent was also considered. A post-operative corrected distance visual acuity, axial length, anterior chamber depth, and follow-up time was also taken into account. Coming to the results, so we can see that in the eyes with post-operative refractive astigmatism, the toric group, we can see that it has shown the maximum reduction, almost 77 to 78.5% of the patients have shown their residual astigmatism to be less than 0.5 cylinder, whereas followed by the limbal relaxing incision group, which is in its 60s. However, the uncorrected group has shown the least improvement, the maximum residual manifestation and least improvement in the astigmatic power. In the toric group, we had the Tory group comprised of 25.1% of the total sample size. The LRI group comprised of 14.4%, and the uncorrected group was the largest group, comprising of 60.5% of the total sample size. Patients in the uncorrected group were older than the other groups. However, this was not found to be clinically significant. And the differences in the preoperative corneal astigmatism, this remains statistically significant, in which the against the rule astigmatism was difficult to treat. About 87, we also took into account the incision and its location. So 87% of the incisions were temporal and the others were superior. It was temporal incision was also the most common incision site in the individual categories as well. Among the Tory group, 89.1% patients underwent a temporal incision. This value was 85.4% in the LRI group, and in uncorrected group, 86.5% of the patients underwent a temporal incision. Overall, the mean incision size was 2.44 plus minus 0.16 millimeters, and the range was 1.2 to 3.2 millimeters. The most important result that we were taking into account was the manifest astigmatism, and this was the least in toric IOL, followed by limbal relaxing incision, followed by the uncorrected or the patients which did not go any intervention. So the residual manifest astigmatism, this was irrespective of the preoperative corneal cylinder. It was consistent in the toric group. However, in patients with limbal relaxing incision or uncorrected group, if the preoperative corneal astigmatic power was high, the residual manifest astigmatic power was also high. Coming to the interpretation, with this study, we can infer that toric IOLs provide the most consistent and accurate correction of low corneal astigmatism. The incisional methods, that is limbal relaxing incisions and astigmatic keratotomy, they are moderately effective, but they are less predictable. The group of patients without astigmatic correction achieved considerably poorer outcomes, especially when the eye had an against the rule astigmatism. The eyes with preoperative with the rule anterior corneal astigmatism close to 0.75 cylinder achieved less than 0.5 dioptric of cylinder of astigmatism in more than 70% of the eyes, irrespective of what procedure was performed for them. So for clinical implication, we can say we must address even the low astigmatism, and the toric IOLs are preferred, provided they are cost effective and affordable for the patient, and if they are available in the power that we want to implant in the patient. Extrapolation, the results apply to patients undergoing routine cataract or refractive lens 0.75 to 1.5 diopter of astigmatism. Toric IOLs gave reduction in residual manifest astigmatism in 77% of case, but they are expensive and their availability for lower astigmatic power is questionable. The current article mentions the lowest astigmatic power available was 1.25 diopters. In limitations, we can say that this study had a retrospective design with a short follow-up, and the cost and accessibility of toric IOL is questionable. And there's also a geographical bias given that the patients enrolled were from US and Canada.
Thank you so much, Dr. Vidushi. Can we have our monthly mentor of the day, Dr. Samir, with his inputs?
Yeah. Very good evening to everyone. And thank you, Dr. Niranjan and YOSI for this opportunity. Vidushi, you can stop sharing. So actually, first of all, great presentation. So as you know, cataract surgery is evolving slowly. We are patient expectations also keep on rising. So almost all patients are now expecting results which are very close to a refractive surgery, which is 6/6 or even sometimes 0.65. So astigmatism is something. So literature reports that almost 40% of the patients that we encounter have an astigmatism of zero point 0.7 or above. So this article addresses exactly that, the lower astigmatism range. So literature had already shown that the for had already been shown the effect of toric and other astigmatism correcting procedure for the range for 1.52 and more than that. So this is basically addressing the lower astigmatism powers. And what this article shows is, obviously, like, the conclusion is that the toric IOLs are probably the best way to correct astigmatism among all the three subcategories, whether it's 0.75 to 1, 1.1 to 1.25, or 1 point, or more than 1.25. Something which was very, very interesting was the incision location. So if you see that 70%, almost 70% of the patients had received a temporal incision, and majority of the patients also had an against the rule astigmatism, which is natural at this age. So ideally, if you see, the incision usually flattens that particular meridian. So by convention, or logically, the incision should have flattened the against the rule astigmatism, should have decreased the neutralized the against the rule astigmatism. But the paper showed that the residual astigmatism was contradictorily much lower in the patients with the rule astigmatism. So the reason for this was the posterior corneal astigmatism, which is usually not affected. So what happens is, the anterior corneal astigmatism is mostly with the rule at a younger age group, which then switches to against the rule. Whereas the posterior corneal astigmatism is against the rule throughout the life, and there is very minimal change in that. So what happens with the rule astigmatism is, in LRI groups and the patients where no astigmatism correction was done, the with the rule astigmatism gets compensated by the against the rule astigmatism, which is on the posterior corneal surface. So that was something which was very, very interesting in this particular article. Apart from that, yeah, obviously limbal relaxing incisions are very unpredictable. They compromise the integrity of the cornea. They vary surgeon to surgeon very drastically. And toric, even making an if you're not taking any astigmatism correction as such and just making an incision at the steeper meridian, again, that is also quite unpredictable, because the SIA might vary for surgeon to surgeon. And you have to actually measure or monitor it by doing your post-op keratometry. When coming to toric IOLs also, so usually toric IOLs are indicated in our institute at Arvind Eye Hospital. We are usually advising toric IOLs for a cutoff of 1.1 diopter against the rule astigmatism, and 1.25 for with the rule astigmatism. This cutoff is much lower for multifocal IOLs, which is 0.75, because the effect of astigmatism increases drastically for when you are implanting a multifocal IOL. So usually it is not advised for pathologies which have progressive corneal disease, for example, peripheral ulcerative keratitis, dense CDKs, or even a progressive fleshy pterygium, where the astigmatism is likely to change over a period of time. Apart from that, also depends on the axial length. So we usually, if the axial length is more, the bag tends to be a larger. The capsular bag tends to be larger and tends to be a little weak. So there are more chances of post-op rotation. So in such cases where the axial length is more than is 25 or more than that, we usually counsel the patient for Alcon torics. They usually have a higher overall diameter, which is of 13 millimeters. And we have also seen to have more post-op stability in such cases. And technique, it completely varies. Usually we should be inflating the bag with cohesive viscoelastic before implanting the IOL, so that it's much easier to remove after the IOL implantation, because one of the very, very common causes for post-op rotation of toric IOL is retained viscoelastic. Another way to do this is by doing hydroimplantation, which is basically you're implanting the IOL under irrigation alone. Third is, so how much does rotation affect in such patients? One is, for every one third, for every 10 degrees of rotation, one third of the toric effect is lost. So after 30 degrees of rotation, suppose I implant the toric IOL at 90 degrees and post-op I see it at 120. So the toric effect has completely gone. Beyond 30 degrees rotation, it actually starts acting on the opposite axis and probably worsens the astigmatism actually. Apart from that, I think that is the thing. The one more important thing is the astigmat, the cylindrical power that we are implanting is actually different from what it actually acts at the corneal plane. So there are actually two components of astigmatism. One is the corneal astigmatism, one is the lenticular astigmatism. You are actually neutralizing the lenticular astigmatism by removing the lens. So whatever you are supposed to neutralize is actually the corneal astigmatism. So by implanting the lens, a cylindrical and by a toric lens, you are actually counteracting the corneal astigmatism. And for example, if you are implanting an IOL which has a cylindrical power of +1 diopter, so it is not actually the entire 1 diopter acts at the corneal plane. It is actually almost 0.5 to 0.6 diopter. So, if you are having a corneal astigmatism of 1 diopter and you try to neutralize it by a toric IOL which has a 1 diopter cylinder, you'll definitely have some residual astigmatism. So that is something which should be definitely considered. And in India or overall in worldwide also, not many not many companies manufacture very low powers of toric with low powers of cylindrical powers. I think Alcon has has 1.5. Icril has, I think in India has the lowest, which is from Biotech, which is 1 diopter cylinder. So that is something which should be considered, and definitely even for 0.75, depending on the indication, the affordability of the patient, whether actually patient requires 6 by 6 or not. All these factors should be considered before taking a call whether this patient requires a toric IOL or not, because you are promising the patient that you will be giving a spectacle free distance vision in such patients, and they have to pay a much higher cost for that. And in case you don't achieve that or the patient do not actually require that, then you'll have a tough time handling the patients. So I think that is it from my side.
Thank you, Samir. Thank you for the comprehensive outlook. I think you've covered almost all aspects of involving astigmatism with cataract surgery. And as you can see on the screen, Samir's accolades speak for themselves. So he is a prolific surgeon, does high volume surgery, and has in-depth knowledge of cataract. And we're very happy to have had you as the monthly mentor for today's evening. Thank you once again for your inputs. With that, let's
Thank you.
move on to the panelists for today. We have Dr. Nikunj Thang. He is an ex-associate consultant surgical trainer, cornea and cataract services, RIU Sitapur, presented papers and surgical videos at national and international conferences, and is the chief editor of YouTube channel, beholding vast videos, and assistant editor YouTube, which is the official YouTube channel of YOSI, and associate editor at Global Journal of Cataract and Research in Ofthal. And next panelist for today is Dr. Bhavya. So I think we're going to need the entire session to finish reading his CV, so I'll keep it short. So he's a highly experienced senior cataract surgeon, refractive and a glaucoma surgeon, trained at prestigious Shankaradeva Nethralaya and Nagari Eye Hospital, and he has performed thousands of cataract surgeries and is affiliated with the ASD Eye Hospital for more than 4 years and has won several awards. We'll start with Dr. Nikunj. Over to you, and then Dr. Bhavya can take over.
Yeah. Hi, Niranjan. I'll just request if Bhavya can go first. I'm actually driving and stuck in a very bad traffic, and then just get back in 2 minutes. Yeah.
Sure. Bhavya.
Yeah, brilliant presentation, Dr. Vidushi. Amazing. I guess Dr. Samir has covered almost a plethora of things related to these things. Because we are youths, we are young ophthalmologists. I guess a lot of our, viewing audience, a lot of our target audience are the people who are eventually gearing up with their FACOs and their learning curves as well. So, Dr. Vidushi, if I may just discuss with you at this moment of time for some, preclude of what these techniques are, because we already know from this paper that toric IOLs have their best merits. There are some other, plus and minuses with other techniques as well. So, have you specifically observed the toric IOLs, or have you come across any practical tip that you may think or you may believe when you have seen in your institutions, that how does the toric part work? I mean, what, like a patient walks in and you discover that the patient has probably minus 1.2 of an astigmatism, then do you have any idea of how the workup happens, or how do you take it from there? Do you have any idea about it?
Yes, so when a patient comes with a toric, when with a high astigmatic bar, first thing to be assessed is whether this patient really needs, whether this astigmatic bar really needs to be addressed, if the patient really needs that 6 vision. And then with the we go ahead with the keratometry, given that before we take the patient up for surgery, before we block, in case we are blocking the patient, we always do the marking for these patients, then go ahead with implanting the toric IOL on the selected axis.
Wonderful. So just a practical tip. Now that's brilliant so far. That of course you're placing the toric at the particular degree that you have done. The best and the most important time in a toric workup is the first post-op day. That is the second day on which the patient comes. So, Dr. Vidushi, whenever the patient comes, you see the AR values. You note a lot of times there's some residual astigmatism which you discover, and that is the right day when you come to know, because in a lot of torics of different companies, if you come to know it at a little later stage, and it's absolutely normal and happens with the best of the best surgeons, that 5 degree 10 degree toric is, suppose you wanted it to be at 120 degree, and the toric on post-op day 2 you discover it is at somewhere like 135 degree. So that is the earliest when you discover that your toric has rotated. That is the best and the easiest time to rotate it. Are you with me so far? The two reasons
Yes,
are, there's not a lot of adhesions that are formed, and second thing, there's some amount of cycloplagia or some amount of dilatation if you're going to use humide, etc., etc. So on the second day, in a very practical setup, if you tell the patient that we might have to take you to the OT for just 5 or 10 seconds, it is pretty much, the patient is already having those NSAIDs, painkillers, all those drops. So usi wave mein, in the same wave, that gets done. That's tip number one. A second tip which we have been observing is a lot of young ophthalmologists are going to take up phacoemulsification. They're already learning right now. They're going to eventually, start doing higher numbers. As much as this sounds for a fresher, to change your site of incision in the beginning of your career is not that easy as much as it sounds. If you have learned it in a temporal way and you are entering the eye at 180 degree, suppose your toric requirement is in a right eye at something like 40 degree, even if you sit on the superior end, the nasal side comes. Are you getting my point? So, not always is changing your site of incision a very easy technique, especially in deep socket eyes, especially if it's a small pupil, if it's a brown cataract. In the beginning of your career, changing the position of your incisions would not be extremely a comfortable thing to do. So, at these moments, toric IOLs come as a savior. And the third practical point, as a beginner, somehow because of the price or because of the entire concept of astigmatism involved with toric, I see a lot of juniors who come to me and say that I've done 1,500 cataracts, but I've never done a toric. There is an unnecessary fear related to toric inside our brain. Honestly speaking, there is nothing different about toric. You just have to rotate it as you rotate the normal lenses. And a very practical point, which I've seen in a lot of private practices, a few private ophthalmologists have stopped explaining toric to the patient. For example, a normal lens would cost something like XYZ amount. A toric lens would cost something like XYZ plus 500 rupees. So rather than complicating the patients by explaining them, a lot of private practitioners have decided that even if we have to put toric, that is our duty, like that goes from our margin, and they virtually implant toric in all the patients. And the last fourth practical tip that I would want to, I do that. I learned it from one of my seniors or guru, Dr. Girish Shetwa sir. He has drawn, the 180 to 0 degree mark on the OT floor itself, where the microscope is concerned. So he, now what we do is we settle our stool accordingly, the OT chair or the OT stool. A lot of times in the OT in high volumes, at times 90 degree, 180 degrees, 70 or 130, we'll end up getting confused between these degrees. So that's the right way to go about it. So that these are the practical tips. Apart from that wonderful presentation, the house is yours. All the best.
I just wanted to ask one thing, like to obviously I heard Bhavya sir, but Anujit sir is there, Nikun sir is there. Like in case a case requires redialing, when do you actually take for redialing? Because what we actually do at Arvind is we actually wait for 15 days because the IOL is still likely to undergo rotation in the upcoming 10 or 15 days, and that is when we actually decide, we do a refraction and see whether the patient is still having below 6 probably 6/9 or 6/12, and whether actually patient is still willing for is unhappy with the vision or something like that. And then probably we will take a call whether it actually requires redialing or not. Because at Arvind, we usually never redial in unless and until it is grossly decentered. Probably one haptic is in sulcus. Only then we'll probably take it on the next day.
I do it in the first week itself. The reason is my
Okay.
second follow-up directly goes to 1 month.
Okay, sir.
That is a very personal thing. I guess I would let Dr. Nikunj or Dr. Anujit. I do it in the first week. Like
Okay.
my first follow-up is on the same evening itself.
So
I call my patient on the second or the third day, and if I detect anything more than say 10 degree or 15 degree, I make it a point to rotate on the
okay.
third of the same day itself.
So because like such patients, we usually make sure we call them after 15 days. And
Oh,
that is also when likely, the adhesions have not formed, which
I
will
that's
allow
a
you for
personal thing. I mean,
okay.
both the line of thoughts are correct, but
Okay.
I don't wait a lot.
Okay. Okay. So what about you, sir? Anujit sir, Nikun
I'll
sir?
I'll I'll, I'll let Nikun sir go first. I think he's in a
Yeah.
nice spot where he's parked his car.
Thanks, Anujit. Yeah, actually, there was a quite busy day, and then there's a lot of traffic, so I just parked so that I can talk about it. So thanks for that. And it was a wonderful presentation. And thank you, Niranjan, for having me here
Thank
as a
you.
panelist.
Thank you.
And I'm looking forward to Matthew Kurian sir's talk. I know him since my NN days, and he's an amazing teacher also. So first of all, yes, suppose I just want to start what I both the points which I wanted to tell, and then I'll come to the IR dialing post-operatively if you feel that there is a rotation of the toric lens. So for the benefit of postgrads, first every postgrad has to learn the reference axis marking. Never, I mean, it is very very important to learn that during your PG so that you don't have that mental block of going to implant toric lenses when you have learned phaco surgery and implanting monofocal lens. Just like Bhavya said that he has people asking him that they have done more than 1,000 surgeries, 2,000 surgeries, but they have not done toric. It's just a mental block because you don't understand a little bit of planning, you don't understand a little bit of how you are going to do little things which are different. So first learn toric marking during your postgrad dates. Try to mark your toric patients for your consultant. If you are working in a teaching institute, so obviously somebody else will be operating, and you can learn marking from that. And then if you gain their confidence, you can start doing the marking yourself. My preferred method is what I think Arvind people do is on the slit lamp with the making the slit rotated at the 180 degrees, and then I mark 0 and 180 degrees on slit with the 26 gauge needle and make a small scratch. Many people, I mean, it's a topic for debate that people use markers and people want to use those apps also to mark. Dr. Saurabh Patwardhan has made a amazing app for toric marking, and I think Zain is using that, and he also has amazing results with that. So that is actually a personal choice. Toric marking is the first thing as a postgrad you should learn during your PG, so that your mental block is taken care of then and then. And apart from that, Bhavya has already taught about how to do a planning for us, because I have a topographer with us, so I do topography for every patient, and you always compare with your optical biometer readings and topography readings. And sometimes I have few patients which I would like to discuss someday on a conference, that there is a discrepancy between these keratometry values, and it makes you so confused that which one to choose, and how to go about it, whether you put toric, because one machine is saying that yeah, it's a patient has a significant astigmatism, but generally topography is the one who is the tiebreaker, and which I follow. So I have patients where IL master 700, or I think it was 500 when I was working in Sitapur, which is showing very high astigmatism. The spherical power also was quite different. And then I did topography, and then did the calculation based on topography readings, and the spherical power was also different, and the cylindrical power was also different, and then I went with and got a good result. So suppose I would have followed the biometer reading, then I would have ended up in a refractive surface. So you need to understand that, preferably if you have, not everybody has access to more than one machines always. So try to have keep that in mind, that just have multiple readings, or at least from the same machine, to avoid such situations. And in our practice, we rotate the toric as early as possible, depending on how much rotation we are expecting. Fortunately, I have got only one or two patients so far where I had to do rotation, especially in post-operative 1 week period. So yeah, I generally don't rotate on post-op day one, until as Samir mentioned, that it is grossly decentered, or there is a the some other issues which are not acceptable on a post-op day one. But otherwise, you can still wait up to a week. Most of the torics which we use nowadays are quite resilient to IL rotation in the bag. And important thing is, you need to have a very well centered circular capsular axis, and it should be covering the optic margin. If your IOL is completely covered all around, there is a very less chance that it can rotate. Apart from that, also you need to remove the OVD from behind the IO, and all those things, which tips which we already discussed. What I want to know from other friends also, including Anujit, that how much as I have come into, once I started my private practice, my threshold for toric has gone so low. I mean, even if it is like 0.7, I'll definitely think about toric first, and offer the patient that yeah, this is also significant, and then we should discuss about the toric lens implant, even if it is monofocal. I'm talking about monofocal also. For trifocals or multifocals and EDOF categories, definitely you need to have that low threshold. But for monofocal also, I've gone low threshold in my practice. So what others opinion on that? Do you offer toric for monofocal as low as 0.7, or something like that? And what is the experience with the because LRIs I don't perform, I don't have access also. I mean, personally I believe that if you have femto, you can do femto LRIs, which may be little more predictable than if you do a diamond knife kind of a blade based LRIs. I do sometime in very rare occasion. I've done just for an kind of an experiment only. I've done paired incisions where you make a similar your keratometry on the opposite axis, where it is the well, I mean, you make your first entry on the steep axis, and the opposite keratometry flatten them on the side. And I have it's predictable. Does any paired incisions, and what is?
So thank you 2 cents on the before we go on to Korean, sir. So firstly, Dr. Bhavya, you mentioned about private practice and threshold for torics. My threshold for torics is also very low. For against the rule, it's zero point 0.5, and for with the rule is 0.75, and it's across the board. I do not use any specific marking, no digital marking. In fact, most of the times I mark on table. I've trained my hand to be quite stable on table. So when the patient comes in, the patient is already dressed and draped. I just make sure the patient looks at the light, and I mark it with the Mendes ring. That's number two. Number three is that there is one thing which I would like to add is that sometimes I've seen that the correction, if you're doing the standard Barrett, the correction on the corneal plane versus correction on the IOL plane is not always accurate. So sometimes the companies will tell you to use their proprietary toric calculator. In those cases, it does come more accurate. I have burnt my fingers once or twice by only doing the Barrett calculation, and it's shown maybe a T2, but in the proprietary calculator it's shown a T3, and that ended up being the right correction. So that's something which I thought that hasn't been added yet in the discussion. And As far as post-op results are concerned, I think it's a little bit prudent to check for the reason for rotation, maybe high myopes, things like that. C-loop haptic, especially there are IOLs with serrated haptic edges which tend to stop rotation after the first 5 or 10 degrees. So maybe those can be observed. But if I know I think at this point of time, there are a lot of notorious toric IOLs that we all know about which tend to rotate. And we may see some conditions in which we are expecting a sort of rotation, especially high myopes with high levels of astigmatism. So those cases I watch, and I'm midway between Bhavya sir and Samir sir. Somewhere I wait for at least a week. And if I feel so, because it's also quite traumatic to tell a patient with toric to go back into the theater. So if they're doing symptomatically better, I leave it as it is. And speaking of patients, if I do the same thing, I do not counsel for toric directly. I just tell them that you have an extra power. Remember the good old days when people would come back for their power correction 1 week later. In this case, if you correct that extra power, you may not need that extra power correction. But I don't promise for spectacle independence in any case. I learned this from Himanshu Mehta sir. He's always told patients that you may need spectacles, you may need sunglasses, you may need reading glasses, you may need blue light filter glasses. So don't consider yourself glasses independent, but definitely consider a better quality of life. So that's, I think, that's my 2 cents on it, but we can discuss this a little bit furthermore. But in the interest of time, I will go ahead with our keynote speaker. So it gives me immense pleasure to be fortunate enough to be listening to Sir today. I've heard so much about Sir. So our keynote speaker is Dr. Matthew Kurian. He has completed his MBBS from Christian Medical College, Vellore, followed by his MS and DNB in ophthalmology from St. John's Medical College, Bangalore, followed by his fellowship from Shankar Nethralaya, Chennai, his advanced management program from Indian Institute of Management in Bangalore, as well as an assessor for the National Accredited Board of Hospitals. And he's been the ex-medical superintendent and the head of cataract services at Narayana Nethralaya, Bangalore, and is the medical superintendent and head of cataract services at the Chaitanya Hospital. And Sir will be speaking to us on oops and near miss in confidence in nucleus management. So with that, Sir, I welcome you to our small webinar, and I hope I hope we get our tips from you. First, I'll for your sharing, sir, and as you please.
Thank you, Anujit. Thank you, Yosi, for this opportunity. Before I go on to the actual talk over here, 2 cents worth from me on the toric talk that was just completed. When there is a misalignment in the toric lens position, you actually have no idea whether the lens rotated or whether primarily for some reason it was placed in the wrong axis. So I do not like to shift my main port incision. It is always at the same point. But in all cases, I try to make at least one of the side ports. I use binoculars where the lens is supposed to sit. So that post-operatively, if it is sitting in the correct axis, in the axis of the side port axis, and that the axis that was chosen by me during the surgery was wrong.
I think,
That
sir,
model
yeah.
is different. Okay. Can you hear me?
So your slides are paused.
Yeah. So I'm not talking
Now
about
it's fine. Now it's fine. Yeah.
Okay. And the second thing is that in most of the cases, you do not, in most of the conferences, you have talks about unhappy multifocal patients, but you never have a situation where you have a discussion on an unhappy toric patient. So I say that toric patients are very forgiving. The technology is forgiving, and all of us should use it. It's much more value addition to the patient compared to a multifocal lens. With that, I'll go on to my near miss and confident nucleus management talk. I have no financial interest on the talk itself, but I am associated with a company called Medip Plus, which manufactures this eye scanner portable OCT. I am associated with Site EMR, that is my company, which does electronic medical records, and we can do a very good offer for YOSI members, and as well as with a company called Autoyos, which is doing a dry eye analyzer. So let's see this video. Beginning phaco training surgeon undergoing training is trenching distally under the rexus, and you can see the flutter which is caused by the posterior capsule rupture that has happened, the altered red glow that is visible there, all of which indicate that PCR has happened. Now, what is the challenge? Why does this happen? Because depth assessment is the critical aspect of cataract surgery, irrespective of the technique. And in terms of what we are doing during phaco, we initially create segments and then we are removing segments. Removing segment portion is the same technique irrespective of whichever method we are using. But when it comes to creating segments, there are multiple methods. Divide and conquer, stop and chop, and primary chop are the three long-standing techniques, and skills required in trenching and cracking and chopping are what is essential, and depth assessment is necessary for this. Challenges in very soft cataracts is cheese wiring, hard cataracts is leathery posterior plate, and in soft cataract, during chopping, you have an inadequate grip as a problem. The techniques that we have discussed here till now are all decades-old techniques. 1990, John Shepherd came up with what we call as in situ fracture. He described it as in situ fracture. We know it as divide and conquer. What divide and conquer was described the next year by Gimbel is actually our stop and chop kind of technique. So in trenching, we are making two long cruciate techniques, trenches. But the problem is that a punch through can happen in the distal portion. Up to midline, no problem, because you are parallel to the posterior capsule. Beyond the midline, what happens is you have to curve up and follow the posterior capsule, and the hardest part of the nucleus is the center. So the foot pedal has to ease up in position 3, otherwise you hit the posterior capsule. So my modification when I was teaching is to go for downslope sculpting described by Gimbel, and that was in 92. So you're making shorter trenches, and the trench is always parallel to the posterior capsule with harder nucleus always in front. So it's very difficult to create a PC rent at this stage. The length of the trench should be smaller than the rexus. It should be very narrow in soft cataracts, and in hard cataracts, it can be wider and deeper to allow the sleeve to enter the trench. And the question was how deep. So deeper makes the cracking easier, but you run the risk of posterior capsule rupture. So this was the question which I was able to answer in the form of a couple of publications. So what I noted was that when we look at the cross-section of the eye, you can see the lamellae which are arranged in parallel layers, and the superficial trench is cutting the edge, and the fiber orientation in the floor of the trench is these cross striations, as you can see over here. This is in the form of a superficial trench. When you go a little deeper, the central trenches are getting cut parallel along the length. So you'll have proximally cross striations, and with a good magnification and depth of focus, you will see these linear fibers in the center. And this is an intermediate trench. And this is what we published in 2018. And this is the most appropriate step for a primary chop. Much deeper, you can see that the almost the entire set of fibers are linear to the length of the trench, and hardly any cross striations are visible. The posterior plate is exposed, and this is a deep trench which is useful for divide and conquer. So this was the Y sign clinical indicator to stop trenching, again published in JCRS in 2013. Now here is a video. You can begin to see the posterior Y suture with appropriate depth and focus. Okay. Now the chopping principles is we want to crack it along the lens orientation, the fiber orientation. The phaco-tip is what is gripping and steadying the nucleus fragment. Second instrument exploits the natural fault lines of the nucleus. So horizontal chop was described in 93 by Nagahara. The phaco-tip impales somewhere in the middle of the nucleus, and the second instrument is drawn to the tip and splits the nucleus. In a vertical chop, the phaco-tip again is impaled somewhere in the middle, and the second instrument goes down vertically to meet the tip, and then there is a lateral separation. Both in horizontal and vertical chop, this lateral separation movement is what is causing the split to happen. So here it is critical to know that you are in the center of the nucleus rather than in a superficial position. And that is where the horizontal chop, if you expose the lens fibers to be in the position where it is an intermediate trench, then it is perfect to do this horizontal chop where you draw the phaco-tip, impale the phaco-tip in the middle, and you are drawing the second instrument from the equator of the endonucleus to the phaco-tip, and then creating a lateral separating movement. In a vertical chop, the movement is a straight vertical dig down, and then there is a lateral separating movement. So a sharper instrument is required for this rather than a blunting or something which has got an inner sharp edge for vertical chopping. So what about a superficial trench? Is this useful for any kind of phaco? So in very brunescent cataracts, this superficial area is actually thick enough, and the phaco-tip can be impaled. You can get a split which will go around the core endonucleus, and then you can do what is called as a petaloid chop. So let's see this petaloid over here. Impaled superficially, the lens matter is separated. There are no forces acting on the core endonucleus. So the core endonucleus is like an interlocking body sitting there. The lens the core endonucleus remains in the middle. So the petals open out. The core endonucleus remains in the middle. And once the core endonucleus is completely exposed, it can be eaten up with the safety of the protection of the superficial portion of the endonucleus outside. So the core endonucleus here is being popped up. It doesn't need to be brought very much into the anterior chamber. It can be still fairly deep inside the bag because the posterior capsule is not going to come forward as lens matter. The nucleus itself is protecting the PC from coming up. Now that the core endonucleus is gone, the individual petals, the posterior plate has to be separated. Once individual petal is completely separated, then this can be eaten up in relative safety and comfort. Segment removal is always to be done in the safe zone. So you go to the periphery, pick up the fragment using a burst of phaco, hold it in vacuum, and then come to the center. And typically, I like to think of the center as being somewhere where the Purkinje reflexes of the light from the microscope is visible. So from that safe zone, safe spot rather than safe zone, I would say, you should not move your phaco tip too much. Stay in the center, use your second instrument and the fluidics of the machine to remain in this place and reposition the fragment so that it is emulsified efficiently. Give a little burst of burst of 3, come back to 2, burst of 3, come back to 2, and using a alternating combination of power and vacuum, the fragment pieces can be removed from the anterior chamber safely and easily with very little chance of surge or PCRs. So my philosophy is that when it comes to the last piece, we have to be extremely careful. Switch your sharp chopper, put another load of viscoelastic, move your chopper into out of the eye and use a blunter second instrument if required. You can use the second instrument to actually stand like a goalkeeper between the lens fragment and the posterior capsule, which is completely exposed. And ideally, you want to modify the phaco settings and come to a little bit more moderate phaco setting. Another option in this kind of a situation is to do what I call as a prophylactic scaffold, which is not to wait for a rent to put an IOL scaffold, but you can do this in the front of a IOL which is inside the bag. Thank you so much for your patience, and I'll be happy to take questions from you.
Thank you so much, sir. I think this is one of the best sessions where nucleus management has been broken down step by step. Uh, Dr. Bhavya, Dr. Samir, you're here. So I just wanted a word over here. So there are two things where residents kind of get stuck in, and one is if you have a soft nucleus and it becomes into a bowl, what to do then? Versus if you have a harder nucleus and it becomes into a bowl, especially the leathery cataracts with a tough posterior plate. So I would just firstly want the YO panel to give their opinion how they have faced this as a challenge, and then I would come to Sir because this is something which is one of the biggest trials for residents. Dr. Samir?
So for softer cataracts, usually what I do is like depends. So I to actually for me,
Let's give you a situation where you've tried to chop, so direct chop hasn't worked. Then you've tried to
okay,
do a sculpt, and it's not cracking, it's cheese wiring. And then you
okay.
decided to go in for the first piece, maybe try to bring in the first piece, hold it by its ear, and take it out. And it's not happening. Meanwhile, while you are going through these steps, not at this point in your career, maybe around 1,000 cases before or something, or 1,500 cases before. So the whole thing has now become into a soft bowl. There are spaces of red glow through the nucleus over here. And right now we know that we can increase the vacuum, decrease the power, and try to slowly bring it out. But for a resident listening, what would be your go-to step at that point of time?
So probably like if the excess is large enough, you can always do a hydroprolapse, get one pole out and decrease the power, use an OVD to coat the endothelium since you will be emulsifying in the AC or probably a little closer to the AC, closer to the endothelium. And I think that is the way to go if you don't have any hold at all.
Hmm, hmm, hmm.
I think
Uh,
that would be the safe option.
Dr. Bhavya?
I keep telling my fellows only one thing, that you cannot have a domino of complications. You are allowed to complicate only at one step. If you have already made a smaller rexus, so you cannot mess with the chop. So I mean, the first tip for everybody listening is that first you stop. uh, Next, whenever saucerization happens, What I specifically do is I usually, like back when I was at say 500 or 1000 cases, what I used to do is I used to try attempt, something which is between stop and chop and direct chop. I would use those small pockets, and with a very vacuum and with a very low power, I would try to topple that nucleus out of that chamber, uh, and then keep on sculpting to a level in which grip, then start them up, start defying. That is how I used to do. Apart from that, another I used to do in case authorization, at a player is some form of wound, I can also attempt using two choppers and try to see if in some or the other way I'm successful in either toppling it out of the chamber, rather of the entire unit, or in some way or the other that I can get a dependent position and then at low vacuum and at low power try to keep eating it. In that process, I've landed up pulling a few bags. I've landed up having a peripheral PCR also, and a lesson learned that preventing saucerization is far better than managing it.
Right. Matthew Kurian, sir, would you like to chip in with 2 or 3 points?
Yeah. So the classical technique that has been described for this kind of saucerization is to do a variation of a chip and flip. Go to the periphery, attempt to hold in vacuum and flip it out of the bag. The problem with that is you feel that you have not got a little bit adequate grip. Your foot pedal accidentally goes into position 3. You're already way into the periphery. You end up with a blowout at that point. So instead of doing the prolapse using the phaco device itself, what I prefer to do is to play it safe. Use either hydro or visco prolapse, get one pole up, and then this happens only in softer cataracts. Okay, so you probably need very little phaco power. Most of the thing can be done in phaco aspiration itself. So it doesn't matter, do it, but do it safely. A little bit of corneal edema is a much better trade-off than having a PC rent. It's less like Bhavya just mentioned, it's less exciting to show complication prevention and much more heroic to show complication management. But from a patient perspective, it is always better to have uneventful, unexciting surgery rather than heroic salvage of complication.
Right. Thank you. Thank you so much, sir. Also, just a couple of words on managing your foot pedal, especially when it comes to foot switch 2 versus foot switch 3. So what happens is when I've seen my residents operate, so when they're getting a little bit flustered and maybe they've gotten a crack in the nucleus and they're working out, they're spending a lot of time in foot switch 3 inadvertently, and then what they're trying to do is that some pieces are coming to them, but before they can establish adequate vacuum, build up the vacuum, they're losing the piece. So we usually watch our residents do that, and we are always telling them that go to the piece, build vacuum, this is a peristaltic system, etc., etc. So when you are seeing a resident do this, not have good control over foot switch 2 versus foot switch 3, is there anything special that you advise them? Is there something that we can pick up from this?
Yeah, the hint I give them is think of children that are getting rid of their milk teeth. So they don't just yank it out first day. They shake it, loosen it, and then slowly they take it. So what I say is foot position 2. While they are there, I'm actually watching the monitor where the foot pedal position is displayed. And I can see what is happening on the video. So I say stay in that position, shake, make lateral movements, little lateral movements before you yank the piece to the center. Build up vacuum, make little lateral movements, loosen it from the epinuclear coating, and then bring it to the center under the Purkinje reflexes. You are in the safe area. Then you go into position 3. So at that point, if there is an inadvertent going into position 3, I say ease up, back to 2, back to 2, back, stay in 2, stay in 2. So when they are getting flustered, I am actually telling them where the foot position is. And then slowly, with maybe 10, 15, 20 times of reinforcement of that, they are also very strong in the proprioception as to where the ankle position has to be for position 3 to position 2. That junction between 2 and 3 is very critical.
Right, sir. Do you, for your residents, do you keep the same percentage for foot switch 2 and 3 on the foot pedal, or in the initial stages, do you adjust it for them, or do you tell them
I
that
keep it, basically they work on my
your
setting.
settings, sir? Yeah.
Yeah. And though I am technically speaking a senior surgeon, my surgery settings are actually very moderate. I use about 300, 350 vacuum, not more than that. My power for soft cataracts is about 40, and for maybe harder cataracts is about 50 to 60, not beyond that. Okay. So it's not how hard you hit, but how well you hit that matters. So it's the delivery of the force rather than the amount of force that creates the fragment.
Right. Thank you. Thank you so much, sir. I think that brings us to the close of this webinar. I would just get one final point from Dr. Bhavya as well as Dr. Sameer. Any other tips you would give for nucleus management, which you have seen have worked for residents, or you see residents usually falter in, and this would be a good place for placing these points out. Dr. Bhavya, would you have anything to add? I would also like to welcome Dr. Prasanna Venkatesh sir, Joint Secretary of YOSI. He's been instrumental in journal clubs for the last 2 years. And sir, would you like to add any points when you've trained a huge number of residents as well, both in cataract as well as in your subspecialty?
Thank you, Anujit. Sir, Matthew, sir, good evening, sir. Nice to see you again here. I was a neophyte in 2013 when I attended the Narayan Netralaya meeting where I looked up to you as well as Sudeep Das sir with awe, and thank you for being here for the young ophthalmologist today.
Pleasure.
Oh, thank you, sir. And I don't know if these points were discussed as a beginner, and our center being again a PG institute. Common difficulties in phaco transition, what I am seeing for beginners are sometimes if they make a smaller excess in soft cataracts, they tend to make as I think one of the discussants were discussing, one complication after the other versus the other, because you can't even do an hydro and get the nucleus out. So they tend to go more fishing into the periphery, and that tends to be a problem. Starting from the rexus, aim a right rexus. Another thing is sometimes even despite doing a good hydro, rotation may happen to have a cheese wiring effect. So then what I have noticed is if you are able to get a good trench and dividing into two pieces at least. So just taking the blunt chopper slightly near the posterior plate. If you're an ambidextrous surgeon, you can do a flip. So when you start pushing from the near the posterior plate, it just flips and comes out into two halves. So that is another thing that needs some expertise as well. But most of the young ophthalmologists I've noticed is sometimes rotation after an hydro delineation. Make sure you have a good rotation. So in the early days, people tend to see that it is not rotating, and then you start doing your trench. So that is when the problem really happens, and going as near to the base plate as possible will cause you to have a punch. Each one of us would have done it at least once in your life. I have my case, I have done once or twice. So because we think it's not dividing into two, and you think you want to go that extra deeper with the trench, and that is when you will have a clear area. That is where you need to stop, because you have now done the punch of the PC, and it's going to go into complication. I think Bhavya told one after the other. And even as Matthews are also told, take that extra time, even if the cornea doesn't clear. I mean, the cornea, you don't have a clear cornea at the end of the surgery, it's okay. Just make sure you do your basics right, as sir was talking about, wriggle it gently and then dissect it out. Sometimes I've also felt use of viscoelastic, sir, to dissect the plane after only if the epinucleus plate is there. I have tried putting cortex settings or even an epinucleus setting on the phaco probe using a viscoelastics to dissect the cleave, and then sometimes it automatically comes out. Once I have had a very bad epinuclear plate, which did not have an anterior leaflet. It was just in the posterior capsule, holding on to it. I was using 5 minutes, 7 minutes. I tried everything. And finally, this one maneuver I did, which really helped me. I used the IA. I'm a bimanual IA person. So I went with the IA probe. I used the irrigation part. I was just able to go below that. And once the irrigation part was below the posterior epinucleus, it just came up on top, and I was able to complete. So just my 2 cents on soft cataract. I think you guys are the experts. I'm more into glaucoma and MAGS. Of course, I do cataract for my bread and butter. But thank you, Anujit. Thank you, Matthew, sir. As I told, it's an honor to have you here for young ophthalmologist. I'm following you for the last 12 years now, and it's always a pleasure to have you here for us. Thank you. Thank you, sir.
Pleasure.
Thank you. Thank you so much, sir. I think that brings us to the end of our webinar. I will just share my screen and just add a few concluding remarks to the webinar. Just a minute. So we have a novel prize distributions or certification at the end of it for our YOSI panel, especially for Dr. Vidushi, who's presented fantastic on a very pertinent topic. So uh, thank you, Matthew Curran, sir, for taking the time out from your busy schedule to be with us today. This will already be on the YOSI archives on the YOSI YouTube channel, and we will be sharing this lecture with all the young ophthalmologists in our sector. Thank you, Dr. Vidushi Dikshit, for being an excellent presenter, for being solely independent. It was a fantastic presentation on a very pertinent topic. Dr. Sameer, words cannot be enough to thank you for stepping up and sharing, not only helping out Vidushi, but also stepping up and sharing your insights, because you do a lot of high volume surgeries. Dr. Nikun sir, for taking out time and sharing his practical points on what he does on a daily basis. Dr. Bhavya Gokani as well. He's always known for making webinars a little bit lighter with his very dry sense of humor, but I think he limited himself today. But nevertheless, thank you so much, Dr. Bhavya. Dr. Niranjan Karthik, for being my partner in crime in this entire webinar series. Thank you, Dr. Niranjan, for being.
Yeah, and sir, Matthew sir, and all the other members who are watching it on YouTube. So this series, we would have seen an introduction, sir, started by Dr. Sonal Kalia ma'am, and Anujit has been very instrumental for the last 5 years. Till the last year onwards, we always had only discussion among YOs, but this year onwards, Anujit and Dr. Niranjan, who has helped us with the panel discussions and the structure of it, we have roped in senior ophthalmologists like you to add your perspective as well, sir. So again, a big round of applause to Dr. Anujit and Dr. Naranjan for consistently doing it every month. And each month we choose a specialty, and today giving importance to only one facet of a particular specialty, that means a lot of difference for young ophthalmologists. And all sir's videos are very pertinent on how you go about your job, especially in a soft cataract, that really summed up the subspecialty. Thank you. Thank you, Anujit, for that. And Naranjan
Thank
too.
you. Thank you, Prasanna sir, for always having our back and controlling the back end so efficiently so that everything on the outside is pristine clear. If you're a resident listening on this, you can be a part of the journal club by screenshotting this or contacting any one of us. Finally, thank you to our academic partner, Microlabs, for always being with us and supporting us through this endeavor. And that brings us into
And
the end.
Anujit, sorry, Anujit. And thanks to Numerotech as well
Numerotech as well.
for
Absolutely.
helping us with all the
I am
seamless
Manjula.
technical glitch. So technical glitch, I think last year you've done a fantastic job.
Thank you. Thank you. And we can end the live streaming, Sai.